So our case, if we remember, the patient had metastatic disease, lung, liver, primary still in place, treated initially with FOLFOX-Bev, probably then went to some maintenance therapy, had a nice initial response. 10, 12 months later starts to show signs of progression, some increasing shortness of breath, marker rising, new CT scan shows some progression. And so now you got to move into second-line therapy. And I think all of us with OX-based therapy frontline would move to ERI-based second line, remembering that this patient has a KRAS mutation. So the question is, does one carry a biologic through to second line? And we have a mountain of evidence that VEGF inhibition through lines of therapy is positive. And so in this case, the patient got irinotecan-based therapy with bevacizumab continued through the front line. So when we go from front line to second line, we have a lot of choices. One is we usually change from OX to ERI, for example. So irinotecan. Many people debate, do we keep the 5-FU going? Most of us do. So we would use a FOLFIRI or even capecitabine. Irinotecan is doable. Where we differ around the world is the use of biologics in second line. In the United States, we have 3 VEGF inhibitors approved in the second line. And most of us continue on with Bev through lines of therapy. You have the randomized clinical trial that supports that, the TML study, which supports a survival advantage by continuing Bev through second line. You already have a patient who's tolerating the regimen, and I never thought I would say this, it's actually the least expensive of the 3. Bev is a bargain relative to the other 2. So I think most of us do Bev beyond progression in through the second line using that rationale. Europeans, other folks, feel like the impact of biologics in that setting is less strong based on the randomized trials, and so choose to stop it. But if you look at our overall survivals and the like, I believe it is that continuation that's getting us to those 2 to 3 years of overall survival. Our patient now has been getting FOLFIRI bevacizumab, about 6 months of therapy, had an initial response, and then has progressed again. New scans based on some symptoms. So the patient's a little bit more abdominal distension, not feeling all that well, still going to work, now still slogging along, doing what they're doing. But on your imaging, you see some new early peritoneal carcinomatosis, which is never a good sign, and some progression of his disease. Performance status about 1 now. Like I say, still going to work, still doing okay. And the question is, what do you do in third line? I think this is a really good candidate for regorafenib. I think the drug itself stabilizes cancers in about half of everybody who takes it, and about a quarter of everybody who takes it stable at 6 months or beyond. And I think because there's not this traditional response seen with the drug, we feel like it has less value, but we don't want to wait too long to use this drug. Many would be tempted to recycle the oxaliplatin in this patient. We had it all the way at the beginning, it's been a year or so ago, and now coming back there. There's not really any evidence that that brings a response rate to this patient either. So I like the choice in this case of using regorafenib as a third-line choice in this patient. When patients get to third line with metastatic colon cancer, it's sort of a great place to do a hard stop and talk to our patients again. Remembering a couple of years ago when we first started with this patient, we were all hope, we were all lots of drugs, we're going to get a few years of survival out of this. And now they've done that. They've gotten a couple of years of survival and they're at a different place. They understand where they are better. They understand that they've got a bad disease that's probably not going to get better. They still want it to get better, but it's probably not going to be cured. And so they are valuing quality of life more. And so this is, to me, a really good hard stop with patients and say, all right, here's where we've been, here's where we are, here's where our choices are going forward. What are your priorities? You know, what's important to you? And then setting out with a strategy. This patient's prognosis untreated is probably 6 months, so fairly short from this point on. And what our overall goal here is to try and kick this down the road. Can we slow the progression? Can we add chunks of time to the overall survival that are meaningful with a good quality of life?